We have just had a debate session. It was very nice and very lively in terms of discussions and questions. Actually, we were together with Dr. Martinez-Rubio debaters for factor Xa or new antithrombin agents. Of course, we presented the data from different point of view, and it seems that the newcomers, well, actually there are many others in the pipeline as well, but the ones that we have the data so far are effective, at least as effective as warfarin. What do you think?
I agree. All three, they are at least as effective as warfarin, and in several aspects are even superior. They are superior in efficacy and even superior in security, in safety, because the new anticoagulant drugs offer less fatal bleeding, less intracranial bleeding, and this is a major word. This is extremely important. So I believe this is an advance. Also, avoiding routinely monitoring, it confers an advantage over warfarin. Although in some special cases, emergency surgery as an example, we would like to have tests. We already know that there are some tests, but not available everywhere. But it's just probably a matter of a short time that these tests are going to be available for special cases practically in every big hospital. So I believe that the new anticoagulants are indeed an advance over the warfarin.
Yeah, particularly given the so-called the anticoagulation gap between the need and the practice. So we know that the data from different sources, epidemiologic data from different sources show that there's a real gap. Only nearly 50% of the patients are anticoagulated. And we know that those who are anticoagulated with warfarin are not really in the therapeutic range. Actually, I learned very funnily from the new trials.
Several that are out of range, and this means a danger. Having a patient that you know that it has very variable INR values, and just to wait till he has a ischemic or hemorrhagic stroke is a very uncomfortable situation. Therefore, having new drugs that avoid these big variations in security and efficacy, this is a major advantage, I'm sure.
It's true that warfarin is a very difficult drug, and I don't really want to have another patient to be anticoagulated with warfarin, because that means you have to have INR values, you have to take care of the INR to try to be in the therapeutic range without complications, without bleeding. Sometimes within the therapeutic range, not even out of range, the patient has, for example, nosebleed. So what to do with that? So these problems are our current problems, and we suffer, and the patients suffer. But on the other hand, of course, the newcomers are not really free of all risk and free of all problems. We do have
sure. However, the interactions potentials are much lower with new antithrombotic drugs. I believe this is a big advantage, because warfarin has many interactions with food and even with lots of very usual drugs, for example amoxicillin or cortisone antibiotics. Several of those will change the INR.
Even with some analgesics,
yes,
paracetamol.
Exactly, and therefore having drugs with very few interactions, this is surely an advantage.
Yes, but of course now we don't need to monitor with the new oral anticoagulants. Well, according to some people, this is an advantage. Yes. It looks like an advantage, but sometimes, could be a disadvantage, as we discussed in the session afterwards. But I think the most important part is when you have complications. because we don't have antidotes so far. Although, you know, there are some
methods to block the effects.
the effects, but it's not so easy. It's not available everywhere. So still, you know, we are coming in this field. But today, indeed, it's an important problem not having the antidote of those drugs. What do you think?
Yeah, it's true, but I would ask you, how many times have you needed to block the warfarin effects during the last year? Probably very, very few. So I assume that with these drugs, that even safer and more precise, we are going to have this problem clinically in less cases. And indeed, we already have data, for example, with the Bigatran, clinical data from blocking the effects using proton blink complex or factor 7 activated, which has function. There are also some few data with rivaroxaban. So I believe this is not going to be a big problem every day. We do not have antidotes.
Hopefully it will be solved.
Yeah.
It will be solved. But not, you know, at the moment it's not an easy problem to just handle.
But I remember, for me, it's like the enoxaparin 10 years ago. We did not have either an antidote from enoxaparin, and we use it, and we are very happy to have used it. And this is very similar to enoxaparin, even in the effects and the working time.
Yeah, it seems that still, well, there is a room to go.
Yeah.
In many aspects. In terms of learning more about the drugs, and we need more data, and we don't have head-to-head comparison of the new drugs.
Completely.
This is for sure, and it's not easy to do that because you know, sometimes it's a matter of course finance and funds to have such trials, and also we are having new data coming from other new oral anticoagulants, factor 10A inhibitors.
Yeah.
One of them is edoxaban, and coming soon, and there are others also coming. And there's only one VKA in the pipeline, as far as I know, and one or two more thrombin antagonists.
Yeah.
But mainly factor 10A inhibitors are coming. So probably the future will be more for the factor 10A inhibitors, oral inhibitors. As we don't have head-to-head comparison so far, we have to probably evaluate and consider the drugs individually and analyze the data as they are in the trials, as the design of the trials are different, and
with perspective. No?
Yes, and different patient population. Some is higher risk, and some are with less risk.
Okay, completely agree.